Less is more. Incorporating minimally invasive techniques into your office treatment protocols. I'm Dan Ward, and I'm in general practice in Columbus, Ohio. I look forward to speaking with you about a concept that has been gaining momentum over the past few years, MID. Minimally invasive dentistry, or minimal intervention dentistry, fits in well with present-day medical and surgical models of healthcare. Trying to be as conservative as possible to preserve as much of the original tissue is a concept that our patients understand and appreciate. This concept is one that guides our sponsor for this presentation, GC America. GC America is dedicated to providing innovative products suited for conservative treatment. Their materials are known to be biocompatible and biomimetic. When I first graduated from dental school, I was anxious to prepare teeth. I'd been trained to make ideal tooth preparations designed to retain amalgam. I was trained to shape the two abutment teeth for a bridge to replace a missing tooth. In my own mind, when I removed tooth structure, I somehow thought I was making the tooth better. After all, I was taking away all that bad tooth that was prone to decay, and I was replacing it with gold or silver. My original concept has changed dramatically. I remember attending a lecture from a wise clinician who said that dentistry begets dentistry. The more dentistry you do, the more dentistry you will need to do in the future. This young lady had most of her teeth crowned as a teenager, and now she's only in her 30s. She certainly is in for a lifetime of dental treatment. The longer I practice, the more I concentrate on preserving the most tooth structure possible. The ideal treatment for our patients' teeth would be no surgical treatment. Prevention has been an important part of dentistry, and we have often been kidded as being the only profession that tries to put itself out of business. CAMBRA is a concept that was developed on the West Coast and stands for Caries Management by Risk Assessment. It is beginning to be taught at a number of dental schools throughout the world. CAMBRA is consistent with the medical model, where we try to influence people to change factors in their lives that are unhealthy and may lead to catastrophic results. CAMBRA promotes the idea that we should evaluate the potential for caries before they develop, rather than evaluating for the results of caries activity after they have progressed to requiring surgical treatment. By considering the likelihood of future caries, we can inform our patients of risks, develop protocols to help reduce their risks, and motivate them to positively change their behaviors. The concept of demineralization and remineralization is important for all to understand. Patients do not go to bed one night without a carious lesion and wake up the next morning with one. There is a constant cycle of acidic attack causing demineralization of tooth structure, and then the subsequent remineralization or replenishment of the calcium and phosphate ions from the oral environment. We as dentists would like to tilt the balance in favor of remineralization. CAMBRA describes factors which negatively and positively affect the balance of this demineralization and remineralization. Negative factors are signified by the acronym BAD: bacteria, acid, and diet. Bacteria evaluation seeks to define the quality and the quantity of the different bacteria within the oral flora. The mouth is colonized by a number of bacteria who are fighting for supremacy. Caries is a bacterial infection caused by specific acid-producing bacteria present in tooth biofilm. There are 30 to 40 known cariogenic bacteria present in saliva. The most common cited are Strep mutans, Strep sobrinus, Lactobacillus, and Actinomyces. These bacteria are acidogenic, which means acid-producing, and aciduric, meaning that they thrive or prefer an acid environment. They produce lactic acid, acetic, formic, propionic acids as waste products from their metabolism of carbohydrates. The critical pH of 5.5 is the level at which demineralization can begin to take place on tooth structure. Acidogenic bacteria produce acids with a pH well below 5.5. Exposure to acids from the liquids we ingest can also produce negative consequences. Young people who consume large amounts of sodas and energy drinks are at greater risk for decay, not just from high levels of sugar, but also from the acidity of their drinks. When a person consumes more fermentable carbohydrates, they selectively favor the proliferation of the aciduric and acidogenic bacteria. Conversely, a person who does not consume as much sugar changes the balance of the bacteria in the oral flora to favor the bacteria that do not produce harmful acidic byproducts. Older patients who use antacids are at high risk for decay. I have observed in my practice patients who had gold inlays and onlays that had been in for over 40 years, and they really had not had much treatment at all through the years that I saw them. They began taking antacids and rampant decay developed. We had to replace virtually all of these beautiful gold restorations that had been in their mouths for all that time. One of the questions now that I always ask when I see a sudden increase in root caries and around the margins of crowns is, are you taking antacids? The acronym associated with positive factors affecting caries risk is SAFE: saliva, awareness, fluoride, and environment. Saliva has a protective neutralizing function. It contains bicarbonate. The consistency of the saliva can be a predictor of potential caries activity. Serous type saliva is the preferred type rather than the mucus type, which is often associated with increased caries. An adequate volume of saliva is important to reduce the incidence of caries. Dry mouth or xerostonia can have significant negative effects. Older people coming to my office take a plethora of medications, and I'm amazed when they come in the door and they plop down this piece of paper, and sometimes it's not a piece of paper, it's two pieces of paper, listing the medications that they are now taking. Dry mouth is the #1 potential side effect listed in the PDR for the top selling medications. An individual taking 4 or more medications has a 50% chance of exhibiting symptoms of dry mouth. Patients who are taking many medications should be closely monitored for signs of dry mouth and increased caries. Several test kits are available for use in the office to evaluate the quality and the quantity of a patient's saliva. Saliva check buffer is a simple way to evaluate the quantity, viscosity, pH, and buffering ability of the saliva. The kit is easy to use. It demonstrates the importance of saliva to the patient and gives the dentist a method to objectively record the status of the saliva. From a legal standpoint, it's a good way to document that the patient has been evaluated and they have been informed of their caries risk. In the event that significant recurrent decay occurs around restorations that you placed. Saliva check mutans is a test kit to determine the levels of strep mutans in the saliva. Strep mutans has been implicated as a leading cause of dental decay. Saliva check checks for the amount of colony-forming units per milliliter of saliva. If the amount is higher than 500,000 CFUs per ml, then it will indicate it on the slide, as you can see on the top with the red line. A high level of strep mutans in the overall makeup of the saliva is a good indicator for the possibility of increased caries activity. The second positive factor is awareness. Communication with patients is paramount in getting them to understand their role in reducing their potential for decay. We as healthcare providers owe it to our patients to inform them not only of the number of carious teeth present, but to also inform them of their disease state, their potential for future decay. And we should explain ways that they can reduce their susceptibility. The third positive factor is fluoride. The ability of fluoride to prevent and arrest caries has been researched extensively. Fluoride alters the critical pH, the pH at which tooth structure can begin to demineralize, from approximately 5.5 down to 4.5. Fluoride is incorporated into the tooth and forms fluorapatite. It inhibits bacterial metabolism. Fluoride incorporated into tooth structure inhibits demineralization during an acidic challenge. Fluoride enhances remineralization and forms a low solubility tooth surface. The final letter of the acronym SAFE is environment. Chemotherapeutics can shift the balance towards remineralization. One way to enhance the ability of the tooth to remineralize is through the use of ACP-CPP, that is amorphous calcium phosphate casein phosphopeptide. Let me say that again. Amorphous calcium phosphate casein phosphopeptide. This unique formulation contains calcium and phosphate, the necessary ingredients for remineralization, incorporated with a unique carrier molecule, casein phosphopeptide. Casein phosphopeptide is derived from milk, and it is safe to use with individuals who are lactose intolerant, but should not be used with those who are allergic to milk. Casein phosphopeptide coats the amorphous calcium phosphate and attaches them both to the biofilm where it is readily available. During an acidic attack, the casein phosphopeptide releases the amorphous calcium phosphate, making calcium and phosphate available for remineralization. ACP-CPP helps to prevent enamel demineralization and also can help to remineralize non-cavitated enamel subsurface lesions in which the surface is still intact. It's also useful in reducing sensitivity by helping to seal open dentinal tubules. These illustrations can help to illustrate the mechanism of remineralization of subsurface lesions. Bacteria within plaque metabolizes the sugars that we consume and produces acid. This acid, in the form of hydrogen ions, can penetrate through the enamel surface to underlying tooth structure. The acid reacts with the tooth structure, demineralizes it, and drives calcium and phosphate out of the tooth. Repeated episodes may result in a visible white spot lesion. When ACP-CPP is present within the biofilm, an acidic attack causes the calcium and the phosphate to be released, which can penetrate into the tooth and remineralize the tooth. As long as the surface remains intact, and that's important, as long as it's intact, the demineralized area can be remineralized using ACP-CPP. Calcium and phosphate ions are released and can remineralize the affected tooth structure below the surface of the enamel. Regular repeated exposure to ACP-CPP can reverse white spot lesions without removing any tooth structure. Several products are available that contain ACP-CPP. The Trident Extra Care tooth gum contains ACP-CPP along with xylitol, another substance believed to help reduce decay. MI paste contains ACP-CPP, which helps to remineralize the tooth and to reduce dentinal sensitivity. MI paste plus contains this ACP-CPP and has the added benefit of 900 parts per million of fluoride. MI paste and MI paste plus are significant parts of my regimens in my office to try to control caries in high-risk patients. MI paste can be used for white spot lesions, for remineralization, to reduce sensitivity during orthodontic treatment and for high-risk caries-prone patients. MI Paste Plus with fluoride can be used for all of the above and for situations where extra protection is needed. It should not be used for children under the age of 6. It can be used as a toothpaste for patients with high caries risk. MI Paste may be applied by using a finger, by using a toothbrush, or by using a custom tray. I have found that the best compliance occurs by fabricating a custom tray for the patient and developing a very regimented protocol for wearing every day. I like for the patient to wear it 5 minutes following toothbrushing, and I'd like them to do it 1 or 2 times a day. No food or drink should be consumed for 30 minutes following application. MI Paste has a number of uses, including reduced temperature sensitivity, reducing dentinal hypersensitivity, reducing sensitivity after tooth whitening. I like to use it during or after orthodontic treatment. I like to use it with xerostomia patients, patients who consume excessive amounts of soft drinks, women with sensitive teeth during pregnancy, and as a saliva substitute for patients with dry mouth. The protocol for adults using MI Paste is to apply after toothbrushing and prior to topical fluoride treatment, before bleaching or root planing, and for the longest time possible. The standard of care for the application of fluoride treatments in the dental office has changed from the topical or a tray application of fluorides to fluoride varnishes because of the extended contact time with the tooth surface with the fluoride varnish. MI varnish adds the benefits of ACP-CPP, which could remineralize the calcium and the phosphate. It is easily applied by a brush following a prophylaxis. The teeth should first be dried and then the varnish is applied. Patients are advised not to brush their teeth or to floss for 4 hours. They should avoid eating hard, hot, sticky foods for 4 hours following application and should not use any other fluoride rinse or gels for 24 hours. The MI varnish delivers high levels of fluoride for an extended period of time. The ACP-CPP helps remineralization and reduces dental sensitivity. In summary, CAMBRA, Caries Activity by Risk Assessment, seeks to identify factors which lead to increased prevalence of caries and to make patients aware of how to reduce their risks. Methods to decrease caries are discussed with patients. The patient is able to make informed choices regarding their role in causing and preventing dental caries. Additional protective features such as ACP-CPP, xylitol, fluoride may be implemented to tilt the scales of remineralization in the patient's favor. So far, in discussing minimally invasive minimal intervention dentistry, we've talked about preventing decay. Now we're going to change and talk about treating decay. What is the most important restoration that we ever place? Well, I believe the answer is the first one. The amount of tooth structure removed may define the future restorative needs of the tooth. Large restorations do not last as long and will need to be replaced sooner with an even larger restoration. Large restorations eventually may lead to crowns. Crowns, unfortunately, from time to time may lead to endodontic root canal therapy, which may fracture. Teeth can be lost. You can see the scenario that I'm painting doesn't happen very often, but really, the dentist that treated the patient for the first time set all of this into motion. I'm a very conservative dentist as far as preparation. I mentioned that the longer that I practice, the more conservative I am with tooth structure. I just don't like to take away or destroy a lot of tooth structure if it is not necessary. So we've been taught to use the 245 or the 330 burr, but I quite frequently love to use the 169L burr, which is a smaller carbide, or even the 201.3 VF, which is a very fine diamond that you can trace the grooves. Another system that's available is the fissurotomy set of burrs that, again, do the same idea. So, now that I've been so conservative and I've tried to preserve tooth structure, how do I restore it? Well, what I found was it's difficult sometimes with traditional high viscosity composites to adequately fill the areas that we have removed tooth structure. And quite often what I would find is I would have air voids. So I quite often will use the new low-flow flowables. Genial Universal Flow is a very unique flowable material. It was designed from the ground up to be used as a flowable material. Flowable materials traditionally are just conventional composites that have had more resin added to them to make them flow easier. Well, this one was developed with homogeneous spherical particles which allowed for higher filler volume. In other words, this particular flowable is filled 50% by volume, which is a significant amount and more in line with perhaps some of the microfill composites that we've been using for years. This particular material also polishes very nicely and it has excellent wear resistance. So here are the restorations as they were placed. Some of these were placed with the Genial Flow and some of these were placed with the Color, with the traditional composites that we use. A challenge that we see so often in composites, and in particular posterior composites, is postoperative sensitivity. And there's not a person that practices dentistry that doesn't see postoperative sensitivity. I sometimes laugh, the only way you will never have postoperative sensitivity is just do not restore teeth. And of course, it's felt that the primary reason for this is fluid flow within dental tubules, the hydrodynamic theory which was described by Martin Brandstrom. Yes, there are other ways that we can get postoperative sensitivity, thermal, heating up the pulp too much, bacterial invasion, micro leakage, but the primary is still fluid flow within dental tubules. So when we are restoring teeth with composite, we need to develop a protocol where we will cut down on the post-operative sensitivity. There are 3 methods to do this. The first method is the total etch technique, which is our traditional 4th and 5th generation materials. Here we have the surface of the tooth, and this is the dentin, and we go ahead and we place our phosphoric acid on it. And if you look at it, you can see that it goes down into the dental tubules, and typically it's going to go down 50 to 100 microns. And then you can also see that we have the area of the collagen fibers right here where I'm pointing to right here. And those are typically 5 to 10 microns. So we've demineralized the collagen. In other words, we've removed the calcium and the phosphate, and we have left then these collagen fibers. All right, and here is as it works its way further down into the dental tubules. Now, of course, we wash it off. I find most dentists do not adequately wash off the acid. I think that quite often they are leaving little bits of phosphoric acid down into the dental tubules, which of course is going to create postoperative sensitivity. It's important that we leave this dentin moist. All right? Then we go ahead and we apply our multiple coats of our resin primer. Now, the challenge is most systems require you to place multiple coats in order to completely seal in the dental tubules. So just because the surface is wet does not mean that there is still resin within the solvent that you're seeing on the surface. So most of them require you to place multiple coats, and most of them recommend that you rub that. Now the challenge with this particular system, that is with the total etch technique, is if the dentin is too wet or too moist, the moisture prevents the resin from going into the dental tubules, and we get the formation of water trees. If it's over dried, the problem is that these collagen fibers can collapse, and we decrease the bond strengths from the formation of the hybrid layer. So what we're always looking for is that elusive, proper moisture. So this is obviously here too wet, and this is too dry, and of course right here is what we're looking for in the middle. That's very hard to define, and it may even be different from bonding agent to bonding agent. Once we've placed our multiple coats on the proper wetted surface, then we need to evaporate the solvent. Now, I don't know about you, but in my experience is when I have my air-water syringe and I push the button for air, what comes out? Right, water comes out. So I find that I feel more comfortable with an air-only syringe. And so I actually have, at each operatory, I have two syringes, an air-only and an air-water syringe. If you only have one, what I recommend that you do is first activate the air away from the patient, and then as you're depressing it, bring it into the mouth. And that way, hopefully, you have drier air. So you can see there's a lot of challenges using this technique, and that's why everything has evolved more towards this, the self-etch technique. It seems to be much more forgiving. It's a unique molecule, and this particular molecule is one that has a methacrylate group on one end and acidic group on the other. So what happens is when you put this on the dentin, the acid side of the primer demineralizes the surface and actually causes the collagen fibers then to be surrounded by this primer, and it also goes down into the dentinal tubules. You'll notice it doesn't go as far down into the dentinal tubules as does the total etch technique, and that has no negative effect whatsoever on the dentin bond strengths. But as you can see, what a great system, because you've never left the dentinal tubules open, because it accompanies the etch down in there. And then when the acid is used up, it has no ability to leach hydrogen ions. It just remains there in place, and we have the seal. It's interesting that the resin tags may not contribute as much to adhesion with the self-etching systems. The challenge with these systems is not the dentin, but the challenge is the enamel. The problem is that because it's not as acidic, it does not etch the enamel as effectively. The pH of phosphoric acid is less than 1, very acidic, but the pH of some of these self-etching primers is in the range of 2.5 to 3.5 to 4. So they are not going to be as effective. And if you recall, the way pH works is the difference between 1 and 2 is 10 times, and the difference between 1 and 3 is 100 times. It's a logarithmic scale. So this is what I have observed in my patients when I have used certain self-etching primers, and patients come back for recall. You can see the brown line that you can see bubbles, you can see all kinds of problems at the enamel surface. So what has developed over the last few years is this concept of the selective etch technique, because the self-etch technique is least technique sensitive. That is, it's less affected by having the proper moisture in the dentin, and it is works better consistently, but it does not do the enamel as effectively. So if we acid etch the enamel and not the dentin, well, that's the best of both worlds. Well, the problem has been this. Until recently, if you got this phosphoric acid on the dentin using your traditional self-etching primers, then it did not bond as effectively. It negatively infected the bond to dentin, and it could cause more postoperative sensitivity. And this was all changed 4 or 5 years ago when Genial Bond came out. This was the first of this is a precursor, one of the first in which you could etch the enamel and dentin if you wished. You could not etch either if you wished, or you could selectively etch the enamel, and yet you still got good bond strengths to dentin. This now, of course, has led to many other products which are known as universal bonding agents, which have this ability, again, to be used under all three modes. Now, I think you know my bias already. I believe in selectively etching the enamel. Selectively etch the enamel for 15 to 30 seconds, wash it off thoroughly, and then apply my universal or my selective etch type of dentin bonding agent. Now, our third method is where we don't even place any acid at all, no phosphoric acid, on the dentinal surface. And that is using our glass ionomers, in particular our glass ionomers and our resin-modified glass ionomers, because you never open up the dentinal tubules. Now, with some of these, yes, we do apply a conditioner, and with that, it's polyacrylic acid. But it is a much, much weaker acid, which does not significantly open up the dentinal tubules. So if you have a restoration that is deeper than ideal depth, I would recommend that you use some kind of a resin-modified glass ionomer lining, such as Fuji Lining LC. And when you're using this particular product, you do not need to use any type of a self-etching primer. If it's larger, then I recommend using some type of a resin-modified glass ionomer base, such as Fuji 2 LC. When you use these encapsulated types, you do want to use some type of a dentin conditioner. That is the polyacrylic acid that I mentioned. So let's go through clinically how I would then treat somebody using what we've just talked about with my typical class 1. This is a young girl, 16 years old. I feel a great responsibility to be as conservative as I can so that she has more tooth structure. So the first thing I do is make my initial opening with a small burr. I like to use, in this case, I've used a 245. Then I like to use a slow speed to remove decay. I think that's something we've kind of forgotten about and should be used more frequently. Then I use my high speed to redefine the prep, and then I like to smooth the margins using a very fine football diamond to remove a fluoride-rich layer on the surface, which ultimately gives me better bonding at the enamel interface. So here are the teeth that are prepared, and now I'm going to go ahead and place my resin-modified glass ionomer. Place it and light cure it. If I put too much on, obviously I can re-prep. I do try to cover all the dentin, as you can see here, if possible. Then we go ahead, we etch it, and wash and dry, and then we put our multiple coats on, and then we build the tooth up. And this is the way the tooth look build up. I like to try to put as much anatomy as I can before I light cure. Once it's set, then I'd like to blend my margins using my finishing carbides, like a 7406 fine finishing carbide. I like to adjust the occlusion and then finish and polish, and then we want to go ahead and put our surface sealant. And when we do that, we acid etch it, wash it, and dry it very well, and then we place it over the two teeth. I feel very comfortable that this young 16-year-old patient is not going to have postoperative sensitivity and is going to have these restorations last for a long period of time. Now, the challenge that we're running into now is that people are wanting us to do tooth-colored restorations. That is just the trend. And what we find is composite sometimes a hard material to work with. I just talked about all the challenges that you can have with the bonding agents, and there are many more that we don't have time to talk about tonight. So we need to be thinking about other types of tooth-colored materials, ones that we can use for dry mouth patients, ones that we can use for our kids that consume so much sweets, those that don't live in a fluoridated water or drink bottled water, and of course our kids that develop some bad habits. And the challenges that we see with composites can be taken care of more easily and more routinely with glass ionomer. The postoperative sensitivity that we talked about due to improper use of bonding agents, you just don't see that with glass ionomer. Recurrent decay. Recurrent decay is the #1 reason for replacing composites. You don't have to worry about that because you've got the fluoride release. It's so important to get the right moisture, like we mentioned earlier. Glass ionomer, much more forgiving. Composite, we always have to deal with polymerization shrinkage, and more importantly, polymerization shrinkage stress. With glass ionomer, you don't have any. It takes longer to do the composite if you do the layering techniques. Glass ionomer can be done in bulk. So to summarize, I mean, all the challenges that you have with composite, you don't have to worry about so much when you're placing glass ionomer. I work with several glass ionomers. This is the particular one that I use more frequently and I have more experience with than any other, and that's the GC Fuji 9. It is available in actually 3 different time settings, a 5-minute set, a 3-minute set, and a 2.5-minute set. And my question to you is, why would you want anything but the 2.5-minute set? 2.5 minutes is long enough. And the particular formulation in this product is improved. It has higher filler particles, higher amount of filler particles, and it releases more fluoride. So this is the one that you want to buy. And we're going to now compare pure glass ionomer, which is what I was talking about, with resin-modified glass ionomer, so you can get a feel between the two. Glass ionomers are more heavily filled, so they have reduced wear. Now that throws people off because most people think resin-modified, that means it must be stronger. Well, it is stronger. It means it must wear less. No, it wears more. Glass ionomers set on their own. There is no shrinkage stress. There is that present with your resin modifieds. Expansion and contraction is similar to tooth. It gives us the highest fluoride release and has this neat property of being bioactive. And that means that when there's an acidic attack, it releases fluoride, and when things neutralize and there is fluoride present, it is reincorporated. There's a reuptake of the fluoride ions into the tooth structure. So there's many uses that we can use with the glass ionomers, and I've given presentations before addressing all of the uses that you see here. But I just want to cover a few things where I find that glass ionomers really excel. First is with pediatric patients. I feel very comfortable prepping into adult teeth, and I'm never that worried about getting into the pulp. But kids' teeth spook me a little bit because it seems like their pulps are so much closer to the surface. So I get nervous about getting in there, and I typically may not clean the dentin surface of a child's tooth quite as not thoroughly, but I'm not making sure that there is no affected dentin on there because I'm afraid that I'm going to end up in the pulp. And my experience has been that when you use the pure glass ionomer, you have less postoperative sensitivity, though we don't get that much with kids anyway, but they seem to stay in the best. I have better retention. That's my personal feelings. I have better retention with glass ionomer than I do with resin modified, and I have better retention than I do with amalgam or with composite. Sealants. I bet you, some people have heard this, but I bet a lot of you have not ever thought about this before. What do you do when the person comes in and there is decay on the surface already, and yet it is not fully exposed? Now, I don't know about you, but I don't particularly want to take this 12-year-old patient and anesthetize him and grab my laser and cut away a bunch of gum tissue so I can get in there and then place my resin sealant. Instead, what you can do is place a glass ionomer sealant. So we place this is the only time where I recommend using phosphoric acid is for the placement of the sealant. And I place it on there, wash it off well dry, and then I mix the material. This happens to be Fuji Triage, which is kind of a pink color, obviously very visible. You can tell if it's still in. And then what you do is to cover it with some kind of a surface sealant, and then you light cure it. Now think about it. You got it all set up, you got it covered. Now ideally keep it dry for the 2.5 minutes it takes to set, but if for some reason you did get something on it, you still can feel better that it's covered up with some kind of a resin, and it will still set. And there it is set. Now this particular one I put in 6 years ago. A patient was just in last week, and I wish I would have gotten a picture of it. These do tend to wear more, but it's interesting. It seems like little microparticles of the fluoride stay within the grooves, and we tend not to see recurrent decay. I was just reading an article today. It was in JADA, Journal of American Dental Association, and they were saying the same thing, that when you had sealants and the resin came out, you had no protection, but when you had the glass ionomer and it came out, it seemed like the protection continued forward. Obviously with class 5s, why would you want to use anything but a glass ionomer in a situation like that? RUCs, I think we should be doing a lot more of these RUCs with some type of a glass ionomer material. This is what I am seeing more and more in my office, and that is cracks within the tooth. I don't know how well you can see it, but if you see my line right here, this tooth obviously was hurting the patient. Every time they bit down, it hurt. Now, if you want to build that up with amalgam, I guarantee you it's going to hurt. If I'm going to put composite in there, I guarantee it's going to hurt because of polymerization shrinkage and shrinkage stress. Why not put something in there that doesn't shrink and something that has a coefficient of thermal expansion similar to tooth structure? Here's our old friend, the copper band that I put around it, squirt it full of that, take my thumb, push it down and hold it for the 2.5 minutes it sets, and there is our RUC. What about this concept of long-term interim restorations? Right, this is a patient, again, that came into my office, and she was saying that every time she bit down on the tooth, it was sensitive. So, take a look. Do you see the crack that's present there when I clean that all out? So, what am I going to put in there? Obviously, a tooth like this, you and I are probably thinking perhaps we should do a crown because we know that it may be sensitive and the crown might help to hold it together. But the patient said she did not want to do a crown, and again, being conservative, as we talked about, we went ahead and we placed our pure glass ionomer. So I acid etched with my phosphoric acid the enamel, not the dentin. I did the enamel, and then I put my polyacrylic acid on the dentin. And then we washed it off real well. We placed our sectional matrices, and we did this in bulk placement. And then once we shaped it, got everything all set, then it's very important that you do all of your shaping with some kind of a fine diamond. You don't want to use carbides because you risk the chance of overheating the material. And this particular material is very susceptible to moisture and being over-dried, and you want to make sure that you keep the moisture within the restoration. So you only use a fine diamond and copious water spray. Then when you're done, in this case I put a Tafelmeyer just around it and painted it on, and we light cured it. So there's the before, and there is the after. I think if we really thought about it, there are so many more applications where glass ionomer, though it does wear more than composite, but might be a better restoration. It might be better because if I put composite in, it obviously, we'd have postoperative sensitivity. If we do a crown, obviously that's a good way to go, but obviously we've taken away a lot more tooth structure. I look at these lasting for anywhere from 5 to 8 years at least. And it's interesting, there's been some studies that have been done, and this again was done on older formulations because to have 10-year data, this is before they came out with some of the new improved higher filler particle materials. But what they found was single surface restorations had a 65% success rate at 10 years. So 2 out of 3 were still there at 10 years. That's not bad. What about multiple surface? Well, they're not as, they don't last as long with those, but they still enjoyed a 30% success rate at 10 years. The way these tend to break is bulk fracture in these larger restorations where you have interproximal. But I have been doing this for over 15 years, and so I just have been going through lately when people come in and I'm looking at their chart from Recon. Let's look at some of these. These are all restorations that were done at 5 years. One place that I like to use them in particular is some of these real deep second molars, upper and lower second molars where it's real cervical. The problem I find with composite is it's so close to the pulp because, as you know, as you go deeper on the root surface, you're closer to the pulp. And people would say that filling you put in just killing me no matter what I did. If I do it with a pure glass ionomer, it seems to significantly reduce the postoperative sensitivity they get. So how long do these things last? This is my guide only. I think 8 to 12 years for a single surface, 5 to 8 for a multiple surface. Obviously, the larger it is, the shorter period it's going to last. But it's kind of interesting because we hear these statistics from time to time where insurance companies claim that some composites are only lasting, 5 years. I don't particularly buy that, but they claim that statistically that some composites aren't lasting as well as we wish that they did. And of course, that's all due to the variability of the person, putting those particular restorations in. So let's say you put in the glass ionomer and something happens. Then what are you going to do? Well, You can always re-prepare the surface, and you can put a composite over top of it, or go ahead and prep it for the crown like we talked about originally. Now, Equia. Equia is the same thing as Fuji 9, but it's a system, and it's a restorative system. And basically, it's placing a pure glass ionomer as your definitive restoration, and then once you're done, placing a resin coating over top of it. And the resin coating over top of it does several things. It helps to keep the moisture in, and it helps it to mature so that it becomes stronger. The surface sealant fills in these micro cracks that are created during the finishing and the shaping. And glass ionomers do have more porosity than do composites. It gives it a nice surface, and this is something will probably last 6 to 9 months. Now, what's different about doing that you may not be used to is that you do not acid etch it beforehand. All you do is wash it off, dry it, and then you apply it. And this shows this photomicrograph of the glass ionomer surface and then the surface when the sealant has been applied. And what they found is if you put the sealant over top of the restoration, that it allows the material to mature. You know, glass ionomer isn't set at the end of the 2.5 minutes. It's still going through a setting process. But by keeping the moisture within it, you allow it to develop ultimately a harder surface with higher micro hardness that will have better wear resistance. Now the resin modifieds. They are different than the pure glass ionomer. There's 2 reactions that occur. There's an acid base and a polymerization reaction. It's dual cured, so it sets faster. So you don't need to keep it dry as long. It is more translucent. There is fluoride release, but not as much. There are, again, a number of uses that you can use the resin-modified glass ionomer. Studies have shown that the resin-modified glass ionomers and the glass ionomers have excellent retention. And in this particular study, it was shown that resin-modified glass ionomer have a significantly higher retention in Class 5 restorations than do resin composites. Now, again, I work with a number of materials, but the one that I have the most experience with is your Fuji 2LC. And so I like to use these for restorations under crowns. Now, let me define for you when I like to use the resin-modified glass ionomer and when I like to use the pure glass ionomer. If I'm going to be doing conventional cementation, all right, so what am I talking about? Conventional cementation, I'm talking about an all-gold crown. I'm talking about porcelain-fused to metal crown. And I'm talking about zirconia crown in which I am just cementing. Then I can use pure glass ionomer and I can use resin-modified glass ionomer, whichever I choose to use. But if I'm going to be bonding the crown, like with Emax, lithium disilicates, then you need to use the resin-modified glass ionomer because resin-modified glass ionomers can be acid etched with phosphoric acid, and they bond better to the resin cement when you are bonding Emax restorations. Now, I know that not everybody bonds Emax restorations, and that is according to your personal preference, and it's also according to the amount of two structure that is available and left. If it's less than 1 millimeter, they recommend that you bond it. If it's greater than 1, then it's your choice. All right. The challenges that we see with polymerization shrinkage and shrinkage stress can create problems. We can develop an open margin. We can have cracked enamel, that is if the bond remains intact to the enamel, and then we have sheared enamel rods. Or the worst thing that can happen is, of course, we can have a fractured cusp. The new nanofill, and in particular nanohybrids, which just about all of the nanofill products are, have the advantage of being extremely highly filled and have lower shrinkage. So as you can see, the materials that are in green are materials that are available that have significantly less polymerization shrinkage than do others. I happen to have worked with Color, which is a GC product, and this particular product is unique in several regards. New composites are going now towards this concept of the pre-polymerized particles. In other words, taking a composite material, polymerizing it, and then shaving or cutting these parts right here, and then using that whole set particle as the filler particle, and then they incorporate smaller sized filler particles, and then they include nanofill particles to try to get it more heavily filled. In addition, this material also uses a different resin. In the United States, the most popular has always been bis-GMA, bisphenol A and glycidyl methacrylate, and with that we add Tegma, which is the dilutant, which makes it so you can handle it. In Europe, they prefer urethane dimethacrylate. Now, this uses a patented DuPont molecule that has a longer chain. And the whole idea is if the chain is longer, well then when the monomer becomes a polymer, then you have less polymerization shrinkage because you have fewer molecules that polymerize. So it's helpful from a shrinkage standpoint, but it's also advantageous because it does not contain bis-GMA. What we're finding is people are hearing about bis-GMA, and some have concerns about that present within the particular resin. Bis-GMA, bisphenol A, is implicated as being estrogenetic. In other words, estrogen mimicking. And so more and more of the companies are coming out with the non-bis-GMA material. Several companies have gone to products that do not contain any bis-GMA, and I do believe that the GC people have taken that as part of theirs. They do not have any bis-GMA within their products. So let's take a look now. This happens to be a case that I did. I was probably one of the first, if not the first dentist in the United States to use this particular product. And so a technician, scientist from Japan flew all the way over, and we basically restored teeth all day long with composite, in particular the Color. We were doing testing of it to see if there were any changes that needed to be made and what we thought of the material. So a patient came into my office and has an amalgam there, as you can see, and obviously has some problems. And so what we went ahead and did was cleaned it all out, and then we placed our resin-modified glass ionomer cement that you can see right here. I like to put it in pretty quickly, and most of the time I'm going to go ahead and re-prepare the tooth. And a little trick that I need to tell you about is to create a little bit of a valley right in the center, so that when you put your anatomy into the tooth, that you have an even thickness of composite everywhere. And then as we can see here, here's our final composite restoration. I really try to restore teeth that look natural and have all the anatomy and the grooves that were present in the tooth when the patient was born. So if we compare the two now, glass ionomers and our resin-modified glass ionomers, we feel that the glass ionomer would work best when it is being exposed to occlusion, because as we said, there's less wear. The resin-modified I tend to like when it's out of occlusion, like in a class 5, or when it's going to be covered up using some type of a sandwich technique. Glass ionomer is great when you can control the moisture for the period of time that you need for it to set. And the resin-modified is better when you are in a hurry and you can't keep the patient dry for that long of time. Glass ionomer is ideally not acid etched, though it can be. Actually, it's better not to put phosphoric acid on it if you want to bond to it. What you're best to do is use one of the 6th or 7th generation bonding agents. You remember we said that they're not as acidic. The pH is not nearly as low as it is when you acid etch. The resin modified works great when you plan on acid etching the tooth. And situations like we talked about with the bonding of the all-porcelain restoration. There's no shrinkage stress with pure glass ionomer. Resin modifieds work best, giving us the best bond to the tooth, because there are two methods. There is the ionic, and then there also is a little self-etching component to that as well. Pure glass ionomers give us the best fluoride release. Our resin modifieds are the most translucent and optically the most aesthetic. So, we've discussed minimally invasive techniques to take care of your patients. Prevention is always the preferred method. If treatment is needed, being conservative leaves more options for a tooth in the future. Getting to know your patient and listening to their wants and desires is so important for success. Communicating the causes for decay, ways to prevent decay, and treatment for decay is being a good healthcare provider. We as dentists need to understand that it's usually best to preserve what is natural. It is our job to help maintain and repair the natural teeth as needed. The new materials and protocols available will hopefully allow us to do that and to help our patients to keep their teeth for a lifetime. Materials. But there are challenges with that. And the deeper that you go within dentin, the lower the bond strengths are. Why? Well, first off, there is less intertubular dentin, that is space between your dentin